Again, good evening. My name is George Protopapas. I'm one of the gastroenterologists here at Valley Medical Group. I've been with the practice about almost 3 years now, and prior to that was working in New York for another 7 years. Today we'll be chatting a little bit about an extremely common condition that comes across our table, across our offices on a daily basis, something exceedingly common, irritable bowel syndrome, or IBS for short. Is something you've probably heard of at some point, whether it's someone in the household dealing with that condition or those symptoms, friends at the dinner table, colleagues at work that deal with it. It is exceedingly common, and again, something that most patients feel as if is a made-up diagnosis or a diagnosis of exclusion. One of my goals here today, this evening, will be to tell you that this is something very real, a very real condition. With sort of definitive criteria and very sort of realistic treatment options that are available out there to help address this chronic condition. Just like any other chronic condition, whether you're talking about rheumatoid arthritis or lupus, there is no cure for this condition. We just hope to try to, gain control of our symptoms so it doesn't take over our life. And again, at the end, please feel free to, post questions in the chat. There is no silly question out there. I hope to try to answer all of them as best I can. One of the take-home points regarding this condition will be that it is a condition that is best sort of treated or managed in a multidisciplinary fashion alongside other members of the healthcare field. It may require a nutritionist, a therapist, a psychiatrist. So this is something that, again, because it may involve other members of the healthcare community, I, as a GI doctor, as a gastroenterologist, may not have that particular information. But again, no question is too small or too silly. So, irritable bowel, or IBS. Most common GI condition that will come across our office doors on a daily basis. We know that it probably affects about 10 to 15% of the population. More commonly seen in women and young adults. The pediatric gastroenterologists certainly deal with some degree of this as well in the younger, population. We see it in anyone from the ages of 18 to 118. In the younger patients, we'll sometimes see it, in or around, when school starts or when school's about to finish. If they are dealing with a financial matter, a personal relationship issue. And we'll go through, how IBS, irritable bowel, how it manifests itself and what are the different sort of factors that are at play when patients develop certain symptoms. There are certain comorbid conditions. So when we see patients in the office and we're trying to get a handle as to what their symptoms may be due to, we often look at their other medical problems because we know that certain medical conditions don't act alone. They sometimes come hand in hand with other conditions. So when we see someone in the office and we see that they have some degree of underlying anxiety disorder, depression, fibromyalgia, migraine history, interstitial cystitis, which is a certain type of urologic condition, or if they're dealing with a chronic pelvic pain condition, being managed by their gynecologist, that, again, they may be more likely to have IBS. Not to say that anyone with anxiety or depression or fibromyalgia or migraines, if they have a gastrointestinal issues, that it's IBS and nothing else. No, we use this part of the history to, get a better understanding. Again, try to do our detective work to figure out, okay, is this consistent with irritable bowel? What risk factors does the patient have? And we use one's comorbid conditions, what they sort of, come along with to try to make sense of it all. Now, there are, different subtypes of irritable bowel, okay? IBS-D is irritable bowel symptoms with diarrhea predominant symptoms. IBS-C is irritable bowel syndrome with constipation predominant symptoms. And IBS mixed is irritable bowel with, both diarrhea and constipation, where patients will sort of flip-flop between symptoms. And out of the three, and there's a sort of an IBS unspecified, where by the criteria that I'll show you soon, that they don't sort of fall into any one of those categories. Now, out of all those subtypes, the IBS mixed component is typically the toughest one to treat from a physician's standpoint. Why? Because I often use the analogy that this is like a seesaw, and you can sort of go from one end of the seesaw to the other in a matter of days, in a matter of weeks, in a matter of months. At some point in their lives, patients with a certain subtype of IBS will flip-flop to the other. That may come over time. It's been shown that a lot of patients will typically go from IBS-D in their younger years to IBS-C over time. Now, what that trigger is, what makes someone flip the switch, so to speak, we're not quite sure yet from a GI perspective, and the science and the medical community isn't quite sure what causes that, but we know the different variables that are at play that could potentially, be behind all this. Not only is it something that, we deal with, when we see a patient and we're talking about their symptoms, we know that it impacts other parts of their life. Okay. Not only, first off, it's the financial impact of all this. We know that in patients, when they're not feeling well, they're either bound to miss work or miss out on, activities with friends and family. We know the productivity at work will decrease if they are not feeling well. We see that often when patients come in and they say, "Doc, I missed X amount of days, X amount of weeks because I wasn't feeling well with, A, B, or C symptoms." The quality of life, you may not miss work, but there are patients who say, "I refuse to go out with my friends for dinner because I know I will get, such and such symptoms." And, third on this, PowerPoint here on the slide is the increased incidence of invasive procedures, right? When someone comes into a gastroenterologist's office or a surgeon's office with certain symptoms, whether it's a change in bowel movements or abdominal pain or discomfort, that they are more likely to get some sort of testing, and some testing can be invasive: endoscopies, colonoscopies, surgeries. And so we know that this, and again, those particular procedures may not be indicated. And the goal of, one of the goals, again, for me during this PowerPoint will be to sort of lay out what that initial workup should be from a gastroenterologist perspective, assuming that the symptoms that one describes to their GI doctor is in line with irritable bowel or consistent with IBS as per the diagnoses that will, the diagnostic criteria that we'll go over. So we know IBS is a disorder of the brain-gut interaction. We know that what's up here and what's in your stomach, what's in your brain, what's in your stomach, are very closely connected in every single person, and no one can or should deny that. And again, what makes one develop certain symptoms of irritable bowel not only is about how that brain-gut interaction works, and again, the science on that is sort of up and coming. You may have seen commercials for microbiome testing, certain neurologic tests that can be ordered or checked. You have to be a little careful about what's out there because everyone's willing to make a quick buck, by selling you some sort of testing that aims to look at or claims to be able to detect X, Y, and Z. But to be quite honest, the science isn't there yet. Yes, the microbiome is an exceedingly important part of all this, and in the next 5 to 10 years, as the science sort of gets flushed out and crosses over from the research side to the clinical side, we'll be able to use that information to make very important, guided decisions, well-based and, research that allow us to treat our patients accordingly. But we know, again, IBS is not only, again, a mechanism of an altered brain-gut axis. We know that there are certain food hypersensitivities that come along with that. The microbiome, which again is not only important in GI conditions, but as you may have seen in the media and the news, that the microbiome is now being linked to a lot of even non-gastrointestinal conditions. Increased mucosal permeability, right? The GI tract is responsible for absorbing and secreting certain, nutrients and chemicals. And we know that that barrier can get impaired over time. And you may have seen the term leaky gut syndrome, which again, I believe it's there will be more to say about that in the next several years, but I think it's something that it's truly in its infancy. And again, something you should sort of be a little cautious about pursuing, whether it's going on Amazon and typing in leaky gut supplement. You'll probably find 45 different supplements that claim to fix leaky gut. Now, there are a wide variety of supplements out there that have been shown to be helpful with one's irritable bowel or IBS symptoms. How effective they are, what part of all this they work on, that again remains to be seen. But again, it's one aspect of all this. Visceral hypersensitivity, meaning how your body, how your gastrointestinal tract responds to what you eat, okay, and how much you eat, whether it's the volume that hits your stomach, okay, the volume or the portion of meals, the components of those meals, right? If something is more gas producing or higher in fermentable carbohydrates, how your body senses that is also at play. And we'll go through, the low FODMAP diet, which some of you may have heard already or read about. That's sort of the mainstay of treatment, initial treatment in patients with irritable bowel. By that, again, hones in on sort of the visceral hypersensitivity and cutting back on certain foods that may help with that aspect of it. Psychosocial factors. I tell patients, listen, I'll sit down with you. We'll talk about, what to eat, what not to eat, what medications to take, what not medications to take. But if one's stress level, anxiety level, depression level is through the roof, anything I say or do from a diet or medication perspective will not help that aspect. So that component cannot and should not be ignored as you're trying to address your gut health. Abnormal gastrointestinal motility, we know that's an additional aspect of all this. In that, again, how the GI tract moves, right? The gastrocolic reflex, when something hits your stomach, how does it send the signal down to the colon to start moving? You guys may have heard of I think it's the Mariko-Aoki phenomenon, right? If you're looking to have, people often say, all right, why do when I go into a Barnes and Noble, if there are any Barnes and Nobles, open anymore, or a TJ Maxx, what is it when I hit that store, right when I go inside, I have to run to the bathroom? The thought is that, again, it's a combination of some degree of the altered brain-gut interaction along with that abnormal gastrointestinal motility, where there's a trigger that sort of sets off your intestine to start moving a little bit faster. And that Mariko-Aoki, again, it was a phenomenon. I guess that term was coined, several decades ago, where the thought was that, when you would go into a bookstore, the smell of books would somehow set off a trigger to, for your GI tract to maybe move a little bit differently. I have patients who know that if they have to have a bowel movement, they'll just go to one of these stores, stroll through it, and they know it'll work for them. And I tell them, more power to you. If that's what helps you go, use that as part of this, treatment approach. And then altered mucosal immune function, which we know, again, different things, different types of inflammatory and immune cells work and sit in the GI tract. And that can get altered, whether it's chronic use of antibiotics, other underlying medical conditions. And again, that's a component of all this that's still in its infancy. Unfortunately, there's no blood test out there. I wish there was a blood test we could just check and say, yes, this is IBS and nothing else. It would certainly make patients feel a little bit better, as if this was truly a real diagnosis. And I'm here to tell you that, yes, just because there's no blood work available that can diagnose or rule in irritable bowel doesn't mean that it's not a real condition. Now, the symptoms of IBS can overlap with other conditions. So symptoms of discomfort and change in bowel movements, right? You can see it in infectious colitis or enteritis. I once saw a patient as a second opinion. She was diagnosed with IBS 30 years ago, 30 years prior. And I asked her, did anyone ever check a stool test for a certain type of bacterial infection of the colon called C. diff? And she said that they hadn't. And I checked the stool test, and she ended up having that particular bacteria. So she went around for 3 decades, close to 3 decades, being told she had irritable bowel when she had a very treatable bacterial infection that, once we got a handle of with a certain type of antibiotic, her, quote unquote IBS went away. So that's one aspect, that can sort of overlap. Celiac disease, we know, is a condition where gluten-containing foods can cause an inflammatory reaction of the intestine, causing the same type of discomfort with change in bowel movements. Lactose intolerance, sort of goes without saying. Small intestinal bacterial overgrowth, where we have too much of the good bacteria in the wrong place. That is a condition that can sort of mimic irritable bowel. Inflammatory bowel disease, so Crohn's disease and ulcerative colitis are chronic inflammatory bowel conditions of the gastrointestinal tract, and patients can have similar symptoms to IBS. EPI, or exocrine pancreatic insufficiency, where one's pancreas doesn't release the pancreatic enzymes that it should. That can mimic IBS. And then endometriosis, a completely sort of non-gastrointestinal condition where female patients get sort of abnormal deposits of uterine tissue and outside of the uterus. That can cause abdominal pain, abdominal discomfort, and a change in bowel movements. So not only can the symptoms overlap between IBS and these conditions, but also, and I didn't put it on this slide, but sort of, it's accurate in that patients can have more than one condition. In an ideal world, every patient would have just one GI condition and that was it. But we know that's not the case. We certainly see patients every day who deal with ulcerative colitis and Crohn's disease, and their colitis or Crohn's disease may be very, very well controlled, but they still deal with bloating and alterations in bowel movements. Just like the average Joe without Crohn's or colitis, they themselves can have IBS. Someone with well-controlled celiac disease who is 100% gluten-free, who continues to have bloating and diarrhea, can also have IBS or a SIBO, a small intestinal bacterial overgrowth over it. So our job is not as easy as one thinks. Everyone thinks if we just order a simple blood test or do a simple endoscopy or colonoscopy. Again, there's a wide variety of conditions, and this is the take-home point of that is that it does require a sort of long-term, strong relationship with your GI doctor to make sure the appropriate testing is done, the appropriate follow-up is done to rule out again, a coexisting condition. So we said that IBS has a real diagnostic criteria behind it. The Rome-4 criteria are design criteria that, again, if you meet this criteria, it is in line with irritable bowel. So patients should have recurrent abdominal pain at least 1 day a week that is associated with 2 or more of the following. That abdominal pain that one experiences is related to bowel movements, meaning, all right, does that pain get better after having a bowel movement? That pain can be associated with a change in the frequency of the stool or a change in the stool form. And this should happen for the last 3 months with the onset at least 6 months prior to the diagnosis. So this is the sort of formal criteria that we look at. Now, there are patients who may be, there with just 1 or 2 months of symptoms, sort of, brand new symptoms. And that, unfortunately requires, continued follow-up to really see if this is the true diagnosis. Having a day of symptoms or a week of symptoms and then seeing a GI doctor for them, they can't definitively say, yes, this is purely IBS. And that should be part of your expectations going and seeing the GI doctor for that first time, knowing full well that when you sit down with him or her, that if there is a possibility of IBS, that you shouldn't walk out of there saying, okay, this IBS, I can go home, rest assured there's nothing dangerous going on. That it does require some follow-up, some testing to see sort of how symptoms unfold, progress, or improve. Patients can develop a post-infectious irritable bowel. The last few months, right, is norovirus season, where everyone's been getting this viral GI bug, which most GI bugs that are viral tend to have a fairly quick recovery. But we know that patients can have a post-infectious IBS where the virus may be gone, but it throws your GI tract off for 6 weeks, 8 weeks, 12 weeks later. So again, irritable bowel can have sort of different presentations and durations. And again, the point of all this is to realize that, yes, there's a very real definition. You see it in front of you here, but also that there's got to be some continuity, especially if someone has somewhat new symptoms. And we said before that IBS has multiple different subtypes, right? IBS mixed, IBS-D, IBS-C. There's a better slide, I think, here. This is the Bristol stool chart. Everyone should sort of get familiar with it. They could probably put this picture, I think, on the Etsy shop. They sell this on mugs. I'm giving a talk to my 7-year-old's first grade class next week. I'll be planning on passing these out to the kids in addition to whatever else I have in store for them. But you should be aware of and be able to explain to the GI doctor what your stool looks like the majority of the time, right? We understand stools and bowel movements can change on a day-to-day basis, on a week-to-week basis. But the goal of all this is, to say, and most patients will say, yeah, doc, it looks like every single one of these. Well, we get that. We're all human. No one ever has the same type of bowel movement, the same, Bristol stool scale number every single day of their lives. Things can change from day to day, whether they're on certain medications, right? People take metformin for diabetes or weight control. Metformin is notorious for causing, type 5, type 6, type 7 stools. Patients can have a stomach bug, and that can, vary, up and down the spectrum here. But when you sit down with your GI doctor, you should have a fair understanding as to where your stools are in the grand scheme of things. What are they looking like on a regular basis, or the most prominent one, for lack of a better word. Now, a little sort of side note that I want to spend some time on here, because it's very easy to just say, oh, I have IBS. There are certain alarm signs and symptoms that gastroenterologists will look for and listen for when they're evaluating a patient, because these conditions, these symptoms up here and signs argue against irritable bowel, okay? So a recent change in bowel movements, number one. Now, like we said before, a day or a week of symptoms could easily be a stomach bug. But if you were normal for your 50 years of existence, and over the last 3 months, for some reason the bowels look different, that is considered an alarm sign or alarm feature that should not be ignored and should be looked at into further. Now, again, if there was a certain medication that was started at the time, a certain dietary change that someone incorporated, if you went on a high protein keto diet and all of a sudden you're constipated all day long, you can theoretically chalk that up to that particular, dietary change. Gastrointestinal bleeding, we know, everything I showed you about IBS and the different variables at play, everything from, hypermotility, or impaired gastric, intestinal motility, or the brain-gut axis being off. None of those should cause bleeding in the gastrointestinal tract. Now, patients can have IBS with hemorrhoidal bleeding. Patients who have IBS with constipation, who strain and push, can have hemorrhoidal bleeding. But, you want to do the sort of appropriate assessment. I remember 8 years ago, a 19-year-old female had come in with, lower bleeding and some abdominal discomfort. And we said, okay, you're constipated with hemorrhoids. And we gave her, a certain type of suppository for her hemorrhoids. She came back a month later, wasn't helping. Tried a different cream for the hemorrhoids, wasn't helping. We said, okay, time to do a colonoscopy because you're not getting any better. She had a polyp the size of a golf ball inside her colon that was slowly oozing blood. So, we take gastrointestinal bleeding seriously, especially because many of you may have heard or read that, young adult onset colon cancer is becoming more and more common. And again, these alarm signs point more towards something like that compared to IBS. Nocturnal symptoms, that is when patients are awakened in the middle of their sleep with the urge to have a bowel movement, not that you woke up and you couldn't sleep and you were, checking TikTok on your phone and you decided to go have a bowel movement because you were bored or couldn't fall back asleep. That's not considered a nocturnal symptom. A nocturnal symptom is it wakes you up out of your sleep, the pain wakes you up out of your sleep, and the urge to run to the bowel, to have a bowel movement. Unintentional weight loss, okay, that is also considered an alarm sign, an alarm feature. Someone who has a family history of colon cancer or inflammatory bowel disease like colitis or Crohn's, those patients are considered a little bit higher risk. And we have to accurately assess and get that detailed family history to really see if someone is due for some form of colon cancer screening. And again, because it is March and it is Colon Cancer Awareness Month, my next couple slides will be on just that particular aspect of it. Iron deficiency anemia. We know that patients will often come here for evaluation of their symptoms, and just perusing their blood work, we'll see that they have some degree of iron deficiency. Now, yes, common cause of iron deficiency can be heavy or irregular menstrual bleeding in females, patients who are vegan or vegetarian, patients who donate blood on a regular basis. But, you don't chalk up iron deficiency anemia, just someone avoiding red meat all the time. You want to do the appropriate gastrointestinal workup, rule out the GI causes, and if we're left with, just someone being vegan or vegetarian, or then so be it. Positive stool testing. We've seen patients who have IBS type symptoms and they come for evaluation of IBS, but someone has done a stool test on them and that ends up being positive, whether it's a stool test for microscopic amounts of blood in the stool or a stool test for an inflammatory marker of the colon, when we'll go through that in a second. And then lastly, patients who are not up to date with screening measures. You'd be surprised how many patients come into a GI office in their late 40s, 50s, 60s, 70s, never having had a colonoscopy, saying, "Doc, I've had 5 months, 5 years, 10 years of symptoms. It must be IBS." And we say, well, you need a colonoscopy because you haven't had one. And we'll sometimes get a lot of pushback and we'll say, listen, we can't see through you. No CAT scan, ultrasound, MRI is reliable enough to look at the lining of the colon as well as a colonoscopy is. So in patients who see their gastroenterologist who are not up to date with colon cancer screening, every symptom that you may tell us, yes, we'll listen to it, we'll document it, we'll go through it. We say, listen, it may be this, it may be that, but no doctor anywhere from here to the ivory towers of Harvard will be able to say that it's not colon cancer unless it's ruled out. So again, something very important in all this. Now, again, an aside on colon cancer screening, only because, it's that month of the year, and March is Colon Cancer Awareness Month. And most of you should be aware that the colon cancer screening age about 4 years ago did dip down from 50 to 45. And we know that the strongest evidence out there is getting checked, getting screened between the ages of 45 and 75. But there's more and more research out there to suggest that, patients who are age 76 to 85, that you can continue colon cancer screening in these patients, assuming they are good candidates for colon cancer screening. Whether it's a colonoscopy, we know that these are invasive procedures under sedation. So we do take one's underlying medical problems and sort of clinical performance status, right? We see patients in their 40s who are not good candidates because they may have either a different type of metastatic cancer or are on home oxygen or have had, extensive cardiac disease. So, that is one aspect of all this, is making sure, patients are screened appropriately before considering or talking about the IBS side of things. And then above average risk individuals, we said that in patients who have a family history of colon cancer, inflammatory bowel disease, or a patient who has a family history of genetic syndromes, that, that history should be flushed out initially, ideally with one's primary care physician first, to determine, the urgency of seeing a GI doctor, right? If someone has 18 family members with colon cancer and they're having symptoms, that particular patient should raise more alarms or bells compared to someone who may have had a second cousin with colon cancer at the age of 90. So getting that detailed family history is very important in all of this. Diagnostic colonoscopy, again, we can do colonoscopies in anyone from 18 to figure out the highest number. Pediatric gastroenterologists will do colonoscopies on pediatric patients for, again, evaluation of symptoms, abnormal blood work, or positive stool tests. And the goal of all this, and I'm sorry if these are too graphic, is to find polyps. We see here polyps range in different sizes and shapes, and we know 95% of colon cancer start off as a little polyp. So the goal of all this is to be able to find these little polyps on colonoscopy, remove them to minimize your risk of developing colon cancer. And here's some pictures of colon cancer in the next, 5 to 10 years. And so again, that's the goal of appropriate, colon cancer screening with colonoscopy. We know there are other screening options as well. The Cologuard stool test is a good sort of plan B option in those who are not looking to undergo a colonoscopy. You may have heard or read about the new blood test that was recently approved for colon cancer screening, which, to be quite honest, still leaves a little bit to be desired in terms of how efficacious it is in detecting precancerous polyps. With time, these blood and stool tests will get a little bit better and a little bit fancier and a little bit more specific. But until then, the colonoscopy is still considered the best test for colon cancer screening. So going back and off the colon cancer screening bandwagon here, So, we suspect someone comes in, they have suspected irritable bowel, but we want to do sort of some initial testing, right? And this is someone, again, who I think has met the time criteria. If someone comes in for a day of symptoms or a week of symptoms, most physicians, most GI doctors probably won't go start ordering all these things unless we see that there's continued or persistent symptoms. Not that because they don't care, just we know that the utility of checking certain blood work and stool tests in certain scenarios is very, very low. So a CBC is designed to look for and rule out any degree of anemia. We know if one's hemoglobin is low, that could theoretically be an alarm sign, like we mentioned before. A CRP is an inflammatory marker of the blood that may indicate, if elevated, may indicate that there is some degree of inflammation going on anywhere in the body. A celiac disease panel, this is a blood test that looks for antibodies that are consistent with celiac disease. A fecal calprotectin is a stool test that, if elevated, indicates that there's some degree of inflammation in the colon or small intestine. Those four are usually what most gastroenterologists will order as sort of a baseline, just to exclude and rule out, other coexisting conditions, the ones we mentioned before. SIBO breath testing, small intestinal bacterial overgrowth, is a very common condition that is usually diagnosed via a specific breath test. That is something that may be considered somewhere along the line based on the severity of symptoms or the duration of symptoms. Sometimes I'll go to that test a little bit earlier if I know a patient is at their wit's end, or if they've been dealing with the condition for quite some time and they want answers yesterday. I know GI doctors were as popular as dentists, so when patients make it to our office, they know they're desperate and they really just want to get X, Y, and Z testing done. And then, like we mentioned before, there's stool tests for certain types of bacteria and parasites that would be done if there's a suspicion that there may be an infectious component to one's symptoms. You'd be surprised how often we'll diagnose underlying bacterial or parasitic infections that can, again, last months or years in one's GI tract, and the patients may not realize it. So we mentioned before, or I mentioned before rather, the low FODMAP diet. This is and should be used as a diagnostic test, right? When you sit down with a gastroenterologist, the goal is to say, okay, you meet the criteria based on what you're telling me, you meet the criteria for IBS. Here is a diet. You would do the diet for 6 to 8 weeks, and then obviously reassessing and reevaluating the patient at that 8-week, 10-week mark to see how one is doing. Because we know if one follows that diet somewhat, closely, that a positive response to the diet, if someone comes back 8 weeks, 10 weeks later and says they feel 75, 90%, 100% better, that is highly reliable for saying, okay, we've pinned down the diagnosis. We're on our way to, figuring all this out. The diet is centered around trying to cut back on the amount of fermentable carbs that one ingests. And FODMAP, each one of those letters stands for a certain type of fermentable carbohydrate that is seen in the most common of foods. The 5 or 6 that I'll rattle off the top of my head as soon as when I see a patient and I'll ask them is, do you eat onions, garlic, cauliflower, avocado, mushrooms on a regular basis? These are foods that, even though they're healthy, no one ever said that onions and garlic are not healthy foods. These are foods that, we know can make you feel very crummy. I sometimes joke with patients in that if you were to eat McDonald's every day, you'd probably feel better than eating healthy all day. Not that I'm advocating for someone doing that, but again, a lot of these healthy foods out there, you tend to take for granted how miserable they can make you feel. I remember as a kid, my younger sister, I would joke with her when I was maybe 7 or 8, and she was a couple years younger than me, that when she'd eat watermelon, I would warn her, hey, don't swallow the seed because a watermelon grows inside you. And she would go crying to my mother because she would have pain after eating watermelon. Now, watermelon is very high in a fermentable carbohydrate. It's a decent fruit overall, but it can make you feel miserable. And no, eating watermelon seeds doesn't cause watermelons to grow inside you, just if anyone had that question later. But again, realize, even the healthiest foods can make you feel miserable. And we know that, again, following the low FODMAP diet, significantly helps with pain and bloating that is associated with irritable bowel. It is more effective in patients who have diarrhea predominant IBS compared to IBS-C. I will give patients that diet just to follow as a guideline in patients with IBS-C, with the hopes that it maybe cuts back a little bit on any pain or bloating that they experience. We know the goal of IBS-C is to move bowels a little bit better than what one is used to. People often ask how much is normal. Normal is anything from 3 bowel movements a day to 3 a week. So you shouldn't be looking for a particular number each day, but the goal is to cut back on the symptoms associated with IBS-C, and that is pain and bloating. The goal when anyone gives you a diet, the low FODMAP diet, no matter who your GI doctor is, the goal is not for you to go home and throw out everything that's in your kitchen cabinets and your refrigerator that that is not in line with, the information that you have in front of you. And I often tell patients, listen, if the diet is going to stress you out more than, anything else in your life, then it's not going to be successful for you. So then, the goal is to use it as a guideline, see which foods are giving you symptoms. It goes through a sort of, I'll go back to the slide in a sec, but we go through sort of different phases. There's the elimination phase where I'll typically recommend patients to follow it strictly, typically for 4 to 6 weeks. I think 2 to 4 weeks is sort of a little too short. And then after that 6 weeks or 8 weeks, the reintroduction phase happens where patients start slowly reintroducing those, quote unquote, bad foods to see how they feel. And then the maintenance phase is, all right, seeing which ones you can sort of live without. Now, this is a process, okay? This is not something that a lot of patients are good with because it does require a little bit of homework on one's end. And most gastroenterologists, aren't trained in nutrition appropriately, to be very honest. It's sort of a sad truth of the healthcare field and GI in particular. Our nutrition, our sort of training in nutrition leaves a lot to be desired. And again, I think across the entire healthcare community, it really shares the same problem. So typically, at least for the elimination phase, we're okay, sort of patients going at it alone, so to speak, in terms of looking at the diet. When it comes to the reintroduction and maintenance phase, that's where patients would stand to benefit with the assistance of a nutritionist, where they can really sit down and look at what they're eating, the amount they're eating, the amount they're reintroducing, how they're reintroducing it, which particular sugars in that, FOD, MAP, which one of those categories are you reintroducing first. Every GI doctor's office you'll go to, they'll usually give you a piece of paper and they'll say, hey, eat these foods, don't eat these foods. What I realized over the last 10 years of doing this is that, with time now, everyone's got a cell phone and everyone's got an app for something. The 2 most popular apps that are out there for the low FODMAP diet are the Monash app, which is on the left, which I believe is a paid app. And the one I recommend to all my patients who I suspect have IBS is the Fast FODMAP app. So if you were to go to your app store and type in Fast FODMAP, you would see that little blue bird icon there in the middle. And when you install it, it has it's a free app, but it has a few sort of annoying introductory questions. But when you open it, it has a lookup feature and a list feature, which you can't see on this picture here. But if you go to the list tab, it breaks down the categories, fruits, vegetables, cheeses, dairy, etc. And everything is color-coded in red, yellow, and green, with the goal of the elimination phase being to take out the red and yellow ones first. So green means go, red and yellow means bad. And so, I often recommend this app because it's easy to follow, it's easy on the eyes, and that everything's color-coded. And again, it just breaks it down very easily for patients. And again, patients carry their phone everywhere. They don't really carry, a piece of paper everywhere telling them what to eat or not to eat. So, the low FODMAP diet, like we said, IBS-C, IBS-D, more so in IBS-D. I think patients tend to benefit from that more so than in IBS-C. But the goal with, in the initial approach with IBS-C should be to first start increasing one's fiber intake. Okay, we know that soluble fiber intake, the goal should be 25 to 30 grams a day. Now, the problem in GI when someone is sort of tired of feeling miserable and they just want to feel better, they go all out, right? You go to that aisle in the pharmacy, you pick up X, Y, and Z things, and you start just sort of overdosing on all this. The general rule of thumb with fiber is you got to go slow. And typically, we recommend that patients start a soluble fiber like psyllium husk or Metamucil, so usually starting with 1 teaspoon a day with plenty of water. We know that water is important in all this, and that you should be aiming for not only 64 ounces of water a day, where that was sort of the number that was always recommended. The thought is now patients should be aiming for maybe 80 to 90 ounces of water a day. But the goal initially with fiber is that, again, you should be increasing it slowly. And again, it is something safe for the GI tract. It's not something that your colon is going to become dependent or reliant on. It's not going to injure or harm your colon, but you have to, go slow. About 3 years ago, I got called to the ER at a local hospital when I was working in New York, that someone was sitting at home one night watching a movie and didn't have any popcorn or any candy. So he decided to go to his Costco-sized jar of fiber gummies and decided and proceeded to, eat about 90 or so fiber gummies over the course of a few hours. And soon thereafter developed abdominal pain and found himself in the emergency room, 4 or 5 hours later with a bowel obstruction that eventually required surgery, because all that fiber that he ate over the course of a couple hours formed pretty much essentially a brick in his small intestine that had to get operated on. So again, I know that's a little bit of an extreme scenario, but again, the goal is to go slow with fiber. Naturally occurring laxatives, we know, come in a wide variety of fruits and vegetables. You'll see here, the different things that patients will often use. And I'm a big proponent of trying to do things naturally initially. Okay. Aloe is something that some of my patients will use because we know it helps with acid reflux, as well as has having a naturally occurring stimulant laxative in it. Not aloe vera from ShopRite, but usually the better kind in health and wellness stores or pharmacies. And then in patients who are not getting better with fiber or natural laxatives, and we know that, as an aside here, as a sort of backpedal here, when patients are sort of at their wit's end, these particular components may not work, right? If someone hasn't had a bowel movement in 2 weeks, if I tell them, go home, start doing a little Metamucil every day, they're not going to feel well. The goal is to sort of clear out and sort of reset the colon, for lack of a better word. And that's where things like over-the-counter medications like Miralax or magnesium citrate may be helpful in just trying to get everything out first. Because if I tell you, go home, have 2 prunes a day if you haven't had a bowel movement in 2 weeks, you're not going to feel well, and you're not going to get sort of the relief that you're looking for. Miralax or polyethylene glycol is probably the most popular over-the-counter option that our patients like. It is safe on the colon. It is an osmotic laxative in that it draws water into the colon. So your water intake has to be sufficient. When I see patients who claim that they don't drink any water or very little water, I don't even offer Miralax to them. I know that it's not going to work. It's just going to sit in their GI tract. And we know that water intake is important in management of IBS-C, especially in the summer months, right? In 4 or 5 months, you'll be seeing 80, 90 degree, 100 degree days. We know that one's water intake has to be significantly more during those summer months. And we often see the repercussions of that when patients come in with more constipation than usual during their summer months, especially in the elderly, because we know the elderly have a sort of different or impaired ability to absorb water or secrete water across their colon. There are a wide variety of prescription medications. So sort of going down the line of natural stuff to over-the-counter stuff to prescription medications. You've probably seen commercials for medications like Linzess, Amitiza, Ipsarella, Trulance. They're all very effective, each with their own sort of drawbacks. But the goal is initially trying to see how you can do it naturally and giving each of these options a shot, right? There are patients who say, Doc, I was constipated for a week. I took 2 doses of Miralax. That stuff didn't work. I give up on Miralax. Realize that's not really how these medications are intended. And the last thing you want to do is sort of go through your 80, 90, 100 years of life, seeing a GI doctor initially, maybe 40 years ago, saying you tried Miralax, it didn't work, and then going through the rest of your life saying Miralax never worked for you. You want to give each one of these a shot. And by a shot, I typically mean at least, 2 to 3 weeks to see how it helps. And again, based on how backed up or constipated someone is, determines, you know, the effectiveness of these medications. And then again, the low FODMAP diet may help with pain and bloating. With IBSD, we know there's a wide variety of medications available, probiotics. To be quite honest, I tell patients if probiotics haven't worked for you over the course of a month or two, then throw them all out. We know chronic probiotic use is something rampant in this country and can predispose ones to developing bacterial overgrowth. So it can actually cause or worsen some of your symptoms, especially as it relates to bloating. Digestive enzymes have sort of taken off in the last couple of years. These are over-the-counter supplements that contain certain components that help break down the fats and the proteins in your diet a little bit better. There's a very common one, a very popular one that a lot of our nutritionists in the Bergen County area like, called Digest Gold, that I'll often recommend to a lot of my patients. And then there are prescription medications that can range from antispasmodic medications, medications that help relax spasms of the GI tract, and then antidepressants. And now when I see patients in the office and I say, listen, I think we have to consider X, Y, or Z medication, and then I tell them that it falls in the antidepressant class, patients are often quick to say, what do you mean, doc? Do you think I'm crazy? Do you think it's all in my head? No, we know that use of antidepressant medications in very, very low doses helps with the sort of neuromodulatory effects on the GI tract. Like we showed you in the first, couple slides, that again, there's a lot of, the brain-gut axis, or how your GI tract responds to, pain or distension, right? The hypersensitivity of the viscera of the organs. And so these antidepressants in very, very low doses can reduce some of the nerve signals to the gut, improve the, sort of the brain pain regulation, and also even help with motility and secretion. Aside from medication, there are other very effective options that are out there. We know that, and again, now with the dawn of, apps for every little thing out there, makes it even more easy to, sort of get in line or get in sort of in connection with some of these therapies that are out there. Gut-directed hypnotherapy, the Nerva app has become exceedingly popular. The Calm app, in terms of stress reduction and relaxation breathing, has been shown to be very helpful in patients who have irritable bowel symptoms. And then cognitive behavioral therapy with the assistance of a psychiatrist or therapist. Again, these are all things that we can't ignore. That again, there's a big part of all this. Again, we can talk about diet all day long. We can talk about over-the-counter supplements and what to take, what not to take, prescription medications that affect the colon. But if one's stress levels through the roof, none of this will help. And that's where some of these apps come into play, in addition to things like yoga, meditation, and acupuncture, which all have been shown to be exceedingly popular in, again, trying to get things moving in the right direction. And everyone's different. And that's where, this is something that, again, requires a long-term follow-up, that you can't, as a patient, expect to see a GI doctor once and all of a sudden be cured of 4 months of symptoms or 40 years of symptoms. Again, it's a very real condition with the criteria that we mentioned before. The success of how we manage this chronic condition, again, is based on having that long-term follow-up with your gastroenterologist, establishing realistic expectations. Okay, I once had a patient 5 years or so ago, 28-year-old gentleman, came in with his grandmother, and the first thing he said to me was, I want you to make me have 3 bowel movements a day, every day, 30 minutes after I eat. And I told him, I'm sorry, that's not a realistic expectation. I don't think any doctor would be able to sort of do that for you. And, making sure that we understand what we're trying to accomplish long-term. And again, that continuity of care is important in ensuring that symptoms move in the right direction. Dietary changes are a key component of all this. We know that's where it all starts, with the low FODMAP diet. And again, other components, physical activity, improved sleep hygiene. We know everyone's sleep hygiene is very, very poor nowadays. Everyone sort of falls asleep with their phone still on right next to them. The stress and chaos of life, we know that gets to everyone and can certainly affect the GI tract. And again, the take-home point from a GI perspective is that every patient requires a different approach. I can't treat my 30 patients that I'll see in a day. I can't treat every single one and their IBS the same way. That everyone will require, a focus on different aspect of their care. So in summary, that's the talk. Here's just a list of our Valley Medical Group GI doctors and where our offices are. I'm in the Montvale office on 85 Chestnut Ridge Road. Paramus is our main hub. That's that huge glass building, as you see here, right next to the new hospital in Paramus. Here's just our Montvale office, as big and fancy as this one is. I kind of like this one better in Montvale, to be very honest. A, it's about a mile from my house, and B, there's easier parking, no elevator needed. Patients like it a little bit more. That's my 2 cents on that. And we can take questions.
All righty, thank you. That was great. We do have a few questions. Did you want to take a look at them, or do you want me to
Yes, I have
facilitate?
the questions here, and I can read them out loud and then
Okay.
answer everyone's questions here. So first question from one of our attendees. I have had every blood test, ultrasound, CT scan, and colonoscopy. Doctor found no issue aside from mild fatty liver. My question is, I have had constant lower intestinal pain and bloating for the past 4 years every day with no period of relief. Is it possible to have IBS symptoms for that long continuously? Everything I read is symptoms come and go. Mine are constant. Absolutely. Patients can have uncontrolled IBS of that severity. Patients can have other coexisting conditions or other alternative conditions, breath tests for SIBO, other conditions and tests. There are, again, as GI doctors, we can literally put you through literally 10 other scans out there. There are nuclear scans of the gallbladder, nuclear scans of the stomach, MRIs of the abdomen, breath tests for X, Y, or Z to look for these other conditions. But these symptoms could certainly be IBS. The question is, have you, has it been addressed appropriately with some of the things we mentioned during this talk? The second question here is, I have IBS-C and type 1 diabetes. I also have a gluten sensitivity and lactose intolerance. In order to keep my diabetes well controlled, not need more insulin, I eat a lot of vegetables. In doing this, I suffer from excessive gas and bloating. Is there anything I can do to control the gas and bloating besides prescription medication? Open to a prescription, but not optimal for me. Thank you. Well, we know, like we said, sometimes eating healthy can make you feel miserable. So it's not to say that, you should be avoiding or foregoing any of those healthy options. The goal would be to streamline it with the use of the low FODMAP diet app, number one, and see how that goes. And especially, I think, in the hands of a nutritionist, especially if someone has coexisting, diabetes. We know the dietary restrictions of diabetes is one huge challenge. And then if you throw an additional component, as something with IBS, then it's all of a sudden, 2 different diets that you have to balance. And again, a lot of times, yes, we want to bump up the fiber, but there may come a point where, again, too much fiber is not the way we have to go about things. That you may need an over-the-counter or prescription medication to allow bowel movements to move faster. Again, there's a sort of a limit as to how much fiber one's body can tolerate. What is the difference between SIBO and IBS? SIBO is a small intestinal bacterial overgrowth that is diagnosed through a breath test, like we mentioned earlier. If someone is diagnosed with SIBO, then there are very specific antibiotics that are given. I'm sorry, I just lost because someone typed and I missed my spot here. So there are very specific antibiotics that are given in very specific durations to help with that particular condition. And IBS, again, we mentioned previously. What is the difference between dicyclamine and hyoscine, and can a person alternate them? These are both, work on the GI tract to relax the smooth muscle of the GI tract. Each of them work a little bit differently. I'm not in favor of one versus another. Some patients like dicyclamine a little bit more than hyoscine. It is a little bit stronger in my years of, sort of prescribing that medication. It can make people a little sleepier than hyoscine. Both of these medications can sometimes exacerbate one's acid reflux. So that is something to sort of keep in mind when taking some of these antispasmodic medications. Okay. I used Cologuard. I'm thinking you were saying Cologuard. I used the Cologuard stool test instead of going for a colonoscopy, and the results came back negative. How does the lab know if I have any growing polyps while using Cologuard compared to getting a colonoscopy where the doctor can see polyps with a camera when performing the test? The Cologuard test is not as good an option as a colonoscopy. Its ability to detect small polyps, right? The Cologuard stool test is a test that tests for microscopic amounts of blood in the stool and DNA in the stool that may hint at the possibility of polyps. I've seen patients who've had a negative Cologuard who a year later have some symptom and they have colon cancer. Now, that colon cancer didn't grow overnight. Alternatively, I've seen patients who had a positive Cologuard and we set them up for a colonoscopy after, and there's nothing in their colon. So again, the false positive and false negative rates with these other alternative options are, still leaves a lot to be desired. If you are having any symptoms, then again, you take that Cologuard out and you throw it in the garbage. Even on the Cologuard website, you can see that it is not indicated in someone with certain types of symptoms. Is there a connection between IBS and gallbladder surgery? We know that after gallbladder surgery, patients can develop a bile acid diarrhea, where sort of the freely flowing bile, bile is made by the liver and typically stored in the gallbladder. Once that gallbladder is out, your liver still continues to make bile on a very slow and sort of, consistent basis. That bile can either reflux up into your stomach and esophagus, causing anything from heartburn to bloating to upper abdominal discomfort, but it can also cause bile acid diarrhea. And in most patients, it's usually short-lived and, usually goes away within the first few months. And in other patients, it could be a long-term issue. And it can certainly cause IBS type symptoms. So, bile acid diarrhea can and usually does cause some degree of abdominal discomfort and diarrhea. My gastroenterologist removed some polyps last year. When do I need another colonoscopy? It's all based on the number, type, and size of polyps. And there's very specific guidelines that gastroenterologists use to determine when that next colonoscopy should be. There's no such thing as, doc, my doctor told me I'm on the 3-year plan or 5-year plan. Everyone is different based on what those particular colonoscopy findings were. Crohn's flare-up just experienced recently. After 5 hours in the ED, all was fine. Maybe he was saying fine. Crohn's flares, if it's truly a Crohn's flare, it's not just going to go away after 5 hours. The likelihood is that you could have, and assuming whatever workup was done in the emergency room was normal and negative, usually it includes some degree of imaging like a CAT scan. If the scan didn't show any active inflammation anywhere in your GI tract and any blood work or stool testing that the ER did ended up looking fine, then it was not a Crohn's flare. It was likely either, again, an adverse reaction to food, a stomach bug, or IBS. Like we said, the average Joe can get IBS, but so can someone who has Crohn's or colitis. Do you still practice in Paramus? Yes, I'm in the Paramus office typically 3 days a week, and in Montvale, I'm usually there Tuesday mornings and Thursday afternoons. On Monday mornings, Wednesday mornings, and all day Friday, most Fridays, I am in the Paramus office. Is there any medication for IBS mixed? We know IBS mixed, like we said, that's usually the toughest patient to manage because patients will sort of go wax and wane through one versus the other. In patients with IBS mixed, I usually focus on fiber and sort of bulking up the stools with a soluble fiber to see how that helps. And then going from there. But again, that's the patient that is usually the toughest to treat. That requires the sort of the longest term follow-up. I have suffered with constipation and hard stools for many years, type 1 on the Bristol stool scale. This caused me to have exterior hemorrhoids. I am diabetic and take metformin. Would Colace help me each day or taking Miralax every 2 days for the rest of my life? Everybody's different. Either one of those options is reasonable. If you're going to try any of those options, I would suggest trying each of them individually for at least a 2 to 4 week period to really say, all right, this worked or this didn't work. Metformin is less likely to cause constipation. Again, it usually causes more diarrhea predominant symptoms in patients. As a side note, the extended release form of metformin usually is a little bit easier on the GI tract. So in patients who have metformin on their medication list, who deal with some degree of diarrhea, I often tell the patients to follow up with their primary to just ask to be switched to the extended release version, because sometimes that little switch is all they need to make them feel better. I have chronic constipation, use Miralax and 1 Colace at night and 1 Colace in the morning. I eat limited lean protein and many fruits and veggies. I also walk several times a week for exercise. It works okay, but is there anything else I can do? That's not going to be solved in this 30-second spiel. We know constipation itself can be, and today we talked about IBS with constipation. There is such a thing as chronic constipation. That is a completely sort of different diagnosis where the pain and bloating isn't part of the symptom complex. And there's many different ways and reasons why someone can be constipated. Patients can have slow transit constipation. Some patients can have pelvic floor dysfunction. Workup of these particular conditions may involve imaging. There are certain types of x-rays that are done called SITS marker x-rays, and even anal rectal manometry. These are tests that are done to look at one's pelvic floor to see if it's working the right way. We often take for granted how many different muscles and nerves are used for one to have a bowel movement. So these are tests that would be indicated if someone is dealing with chronic constipation and is not getting better with the use of some of these over-the-counter medications. Is there any connection to perimenopause and IBS symptoms with regards to hormone levels? Absolutely. We know the predominance of IBS in perimenopausal women is exceedingly high. And again, we use, what we have at our sort of disposal to combat these symptoms as patients go through that period of their lives. Spent 2.5 hours and discharged, CAT scan, clean, had ileum removed 8 years ago in colonoscopy, but restricted access. I'm not quite sure about sort of the details of how you describe that, but if one's had their ileum or distal small intestine removed, there's different reasons why that area has to come out. Typically, it is in the setting of Crohn's disease or chronic inflammatory bowel disease. So for a GI doctor to make an accurate assessment of that, they would need to see prior surgical specimens to see what that looked like before determining what additional testing would be needed. What age patients do we see? I'm an adult gastroenterologist, so 18 and above. Can continued use of probiotics lead to small intestinal bacterial overgrowth? Absolutely. I mentioned that before, that with probiotics, I often tell patients, listen, try them for a month or two. If you're not getting any better, throw them all out. There's tends to be, again, a prevalence of probiotic use in this country that, again, I think is causing a lot of patients to have symptoms. Not that they're not helpful. There is a role for them in the right patient, but you don't want to just blindly take it without sort of accurately, sort of knowing what you're getting yourself into. And I think that's all the questions I see right now that are available.